Thank you everyone who joined and welcome to our State of EVV webinar where we are now. It's session 1 of 3 and we're so glad to have you here today. In this session, we'll be exploring the current national and operational landscape of EVV. With most states now compliant with the Cures Act EVV mandate, the focus is shifting and states are positioned to expand EVV requirements beyond what the law originally prescribed, making this a critical moment for organizations to get ahead of what's next. As a reminder, this session is being recorded and it will be available on HHS Connect's YouTube channel afterwards, so feel free to share with your networks or take a look back at the session later. We want this webinar to be interactive and conversational, so if you do have any questions at any point, please feel free to drop them in the chat. Both Kristy and I will be monitoring and responding through the session. We'll also have a dedicated time for Q&A at the end if you'd prefer to ask questions then. So without further ado, I'm very excited to introduce Kristy, who will be leading today's discussion. And on a personal note, I've had the pleasure to work with her and not only learn more about her EVV expertise and passion for helping others, but also bond with her over her shared love for animals. So Kristy Pyles is the founder and CEO of In Your Corner Consulting, specializing in compliance, operations, and program management for home health organizations. She brings a unique blend of investigative and regulatory experience, including working as a special agent in a Medicaid fraud control unit and EVV implementation for a state Medicaid agency, and has guided clients through CMS certification, major program implementations, and complex claims client compliance initiatives. Now I'll pass the mic over to Kristy, and without further ado, let's get started.
Thanks, Ellie. I appreciate that. And the claims compliance piece is a mouthful. You did a really good job.
Thank you.
There's a lot to unpack
Thank you.
there. As Ellie mentioned, this has been my life. Electronic visit verification, otherwise known lovingly as EVV, has been something I've been living since 2016, and it's something I've been doing as a consultant across the country since 2020, which is a wonderful year to start a business, but it's been very productive, and I've learned a lot of things. So we're here to share that with you. And I think the first thing we wanted to talk about is how has EVV evolved? That in itself is just a whole thing to unpack too. So I don't know if people realize this, but a little birdie at CMS told me that long ago, CMS actually requested states do EVV voluntarily so that they didn't have to implement a rule. And of course, only a few states did it. So that's how we came to know the Cures Act. So the 21st Century Cures Act is where the states are mandated to implement EVV for their providers amongst many different roles. I mean, it can be, we'll talk about that later, but it's different states have different rules. And the way it's evolved is, we had some states go live before 16, before the rule signed. We've had some states go live since then. We still have states going live. So it's evolving every single day. Something new happens. So it's really come a long way. And I think states are starting to realize some of the operational impacts. So it's going to continue evolving as we go down this path. So it's been a fun journey, and I could see us rolling it out into bigger spaces as states learn how their providers are operationalizing everything. But it's also made a lot of improvements. And some of the improvements it's made is the states have listened to the providers and they've said, okay, maybe hospice doesn't belong in this state, or maybe it does. Perhaps PDN services, private duty nursing, they don't belong in here. A lot of states don't have that. They've also worked with CMS to determine what makes sense and what doesn't make sense. So where durable medical equipment is technically in the Cures Act, a lot of states, all of them that I know of, has been able to exclude that from EV just by the way that it's rolled up in their waivers. So that's already being billed for in a different way. So that's not something you have to include. They've also made improvements in their technology. So some states have decided they didn't like their aggregators. They've switched to a different one, more provider friendly. Some have said we want better reporting in our systems. And so they've really been listening. Other states, it's gone kind of stale, and that's probably because they've got a lot they're taking in with CMS. I've got the interoperability coming down the pipe as long as everything else. So states are really trying to pivot and do what they need to do to get compliant. But I could see those states moving forward in the future as well. It's also improved by provider adoption. Providers are starting to understand EVV and what it's for. Providers are actually agencies especially are starting to use it to find their own fraud, waste, or abuse. I've talked to several agencies who said, hey, I didn't know my caregiver was 500 miles away saying they were providing care. So they're already kind of policing themselves. So it's starting to really clean up the landscape so people can get the services that they deserve. It's starting to free up some money for them. So it's been a long way to come, and it's been doing very well. But there's still fragmented. There's still a long way to go. And, one of the things that I hear most from providers and vendors, especially who span across states, is one state has this aggregator, the other state has this one. They have different rules, they have different requirements for reason codes. Some have resolution codes, some have missed visit reports, some don't. Some require billing through the aggregator, some don't. Some require EVV on a claim file instead of through an aggregator. There's a lot of differences, and especially for those providers in multiple states where, we have states that have open model, which means that you can bring your own vendor or use theirs for free. So it's really freeing up the providers to do their own book of business the way they need to. We have states that say it's provider choice. We're going to give the aggregator and you have to bring your vendor, which can be cost prohibitive for some providers because they're not, built to take on a big electronic medical record system. So it's another expense they have to take on. Then we have the MCO option where the state says, we've got 5 different MCOs. All MCOs can get whatever aggregators they want, and then we have to accommodate them. So now our vendor may have to send different files to different vendors. So that makes it more complicated. And if you're a provider working across those states, where some states you can use your vendor, some states you can't, then I mean, it makes it pretty impossible to keep up. And not to include the changes. Some states now are enforcing claims compliance with EVV. And one of the things I've mentioned to providers is, EVV is a policy, and it's been a policy. Claims enforcement is just enforcing that existing policy. So I hear providers a lot saying, "Oh, EVV just went live this month." Well, I mean, it went live a few years ago. Claims denials went live this month. So it's been an education for providers as well, trying to learn the different policies and what those mean. And with states shifting, sometimes not in the best way, it can be very hard to keep up with. And it's one of the things that are coming down. I don't want to go too fast because I know we've got some questions that got submitted beforehand. But it's the posture is shifting in compliance. And as we know that across the country, there's a harder look at fraud, waste, and abuse. And CMS has spent millions, if not billions of dollars on electronic visit verification. So it would make sense that they're going to use it to, try to enforce fraud, waste, and abuse rules. And one of the things that CMS has said is states can go above and beyond the Cures Act. They've said that since day one. And we have seen a couple of states put in rule, even though we know it's allowed to, that they do intend to do EVV the way they need to. So they're already posturing themselves to expand EVV. And it's something that I could see happening, especially across the autism space. There's only a handful of states that require autism services in EVV. So that could be an area that gets scoped out to see if that's possible. Behavioral health in general, because it is a very different landscape and it's one that you want to treat carefully, has not been included in EVV, but we could see that change. We could also see transportation. That's been talked about since the get-go with EVV, trying to include transportation in there. So that's something we could see. But there's a lot of states trying to figure out how they're going to have to change and accommodate any directives that come from CMS. We've also got the electronic authorizations. Some systems with the states take in the authorizations. So it's going to be interesting to see how that changes the EVV landscape, making the authorizations now digital instead of fax or paper that some states still have. So it's going to be an ever-changing market, I think, over the next couple of years. And I think one of the things as providers, we need to be mindful of what's happening in our state and what's happening at the federal level so that we can keep an eye on it, join stakeholder meetings, provide feedback. CMS, I believe it's closing soon, but they have a request for information out there right now asking people, how do you think we could better respond to fraud, waste, and abuse? So that's something that stakeholders, all of us can get on and respond to. My biggest fear is that we're going to have providers paying for something that's in policy. And that's an area of feedback I've given CMS is it's not necessarily the providers that we need to worry about when it comes to this, it's your policies. Let's make sure all of our policies and programs are updated so that providers know how to function and that it's actually working together. Because, even within a state, some of the managed care policies don't align with the state policy. So now we've got providers trying to figure out which one do I need to be compliant with. It's hard to get answers. So we need to really have a streamlined and complementary policy in each state so that providers can be compliant. One of the things that I also say is just because something may look like fraud, it may just be someone that does not know the rule. So they're doing something, for example, I won't call the state out, but there's a state that they have some programs require signature at the end of the service, some don't. So providers think because the EVV signature got pulled out of the EVV program a couple years ago, that signature is no longer required. But what they don't realize is by policy it is. You just can't satisfy it via using the free EVV system anymore. So they may not have been getting signatures on some of their documentation because they thought it got brought out. So I think it's really important as legislators and as enforcers that we look at that and say, with all the different rules and policies and everything we're asking providers to do, is this a mistake? Is this something that anybody could have done had they not known? Or was it really fraud? I think that's going to be very important for CMS and states, MCOs, all the auditors out there. Think about that as you're going through the cases to see what's actually happening. And I think EVV data is going to start getting used more, which is good. I know that, we talk about fraud, waste, and abuse, but there's an angle to EVV that a lot of people don't look at, and I've been trying to push out there a little more, is that we can actually improve care at home by using EVV data. I know that the state that I was in was taking in the EVV data and they're actually applying it to, okay, we have this cluster of individuals with this diagnoses and this particular region, and this is how often they're hospitalized. Are they less hospitalized because now we have more time in the home? Is there a close enough hospital? So they're using that EVV data to try to drive decisions on where to put regional hospitals, how many units to authorize. I think it's giving payers a granular look at what's happening in the home or in the community. And it's saying, well, this person is in the hospital less, the more the person's in the home or with the person. So maybe we should let them be with the person more. So I think it's giving us a better view into what's happening so that people can get better care. And it's also allowing recipients to have better oversight in their own care. I've I love to put out there that I think everyone deserves to have a say in their health care, whether it's at home, whether it's at the doctor. Everyone should be their own healthcare advocate because you're the only one that knows you. And by seeing what people are doing in the home and billing for, you actually have more say and oversight. And you can make sure that that person is billing what they're supposed to be billing because those are your hours and you should get them. So that's giving people more power in their home. So I think EVV is bigger than just the data and fraud, waste, and abuse. I think it's giving people information that they need to make it just better all the way around. So that's I don't know, going to soapbox with EVV and how good it can be, but on the auditor side too, yeah, it's great. I mean, you no longer have to go and request records from agencies anymore. You can just pull up the data and see if people are where they need to be. And as much as we'd like to think it doesn't exist, there is fraud in home health. I mean, that's just the sad fact of the matter. I worked it, I saw it, and it was heartbreaking, some of the things that I saw. But EVV is going to help. It's never going to stop it, but it's going to help identify that quicker. We're no longer looking at 5-year look backs at program integrity. We're looking at real time. So if we have somebody who's been accused of some type of fraud, waste, or abuse, we can look at their data and say, okay, what happened last week, not what happened 5 years ago. And it may actually save lives, which that to me is worth it alone. If it saves one life, all of this is worth it. So I think EVV, even though it's demonized, and I've been guilty of doing that myself, it's actually a good thing on many different levels. One of the downsides is providers are still struggling operationally with it. I think that's something that payers really need to take a look at, and some states do a very good job of it. They're listening to their providers and understanding that, let's talk about manual entry and edits. That alone is coming down the pipe. It already has for many states. Other states aren't enforcing it yet, but this is something that CMS is pushing. So manual entry and edit, I saw even asked today on a webinar, is that just if I manually enter it? I forget to clock out or in, it's okay, right? No. If you touch that visit after it's been collected, that is a manual entry or edit. And many states are saying you're either not going to get paid if you touch a visit after it's been collected, or if over a quarter, if you're over the threshold, we're going to do some kind of PIP on you or performance improvement plan, or some are going to refer you to the Office of Inspector General. Many states are doing many different things, so it's hard to keep up with, and they have different thresholds. 85% is usually the threshold I'm using just as a average across the country. So I've been telling providers, unless your state is actively enforcing it, if it's coming down and you don't know, try to go 85% because if it's lower, you're great. If it's higher, you're close. But that's something that providers really need to stay in tune with today and make sure that their caregivers are clocking in and out when they're supposed to. But a challenge with that is that, not only do providers have to make sure the visit is making it into the state aggregator, They also have to make sure that their authorizations are being calculated correctly. They have to make sure payroll is being submitted correctly and that claims are being submitted correctly. And with EVV data, and I've been shouting this from the rooftops, is if, and especially from a program integrity aspect, if I do a visit from 10 a.m. to 2 p.m. and I say, you know what, I stayed half an hour too long, I just wanted to get some stuff done, I'm only going to bill from 10 to 1:30, and I back that visit down to 10 to 1:30, that shouldn't have any negative effects because now I'm not billing you for what I could. I'm billing you for less. So, one of the messages I've been giving to payers and even to CMS, we need to really think about, should a provider now billing you for less than they originally said that was in the home, should they be penalized because they've now edited a visit? Or should that be seen as, you know what, thank you for being compliant? I think that's something that payers need to take into consideration because if that provider has to balance, am I going to get paid if I touch this visit, or am I going to lose the person is going to lose the services attached to that authorization for that extra 30 minutes? Which side of the coin am I going to take the hit on? Because I'm still not going to be able to bill for the authorization that the service hours came off of, but the person's not going to be able to get the service. So it's a very difficult position for providers to be put in. Also, when you're asking providers to submit claims to the aggregator, you're taking away their ability to run their business because now they have their own system and they've got to marry up between what's in the aggregator and what got submitted to what their revenue cycle management says and make sure everything matches. And in several states, there's no connector. So a different claims number may be put on that claim as it goes out the door for the state solution and have a different number when it comes back in. So there's no way for providers to tie it in the background. So it's creating a lot of administrative burden. That's Cures Act says that they shouldn't happen. Administrative burden is one of those things that are supposed to be limited, but it's creating a big one. And also, if the system's not performing the way it should, we've had that happen. Claims sometimes deny when they're not supposed to, and making sure payers respond quickly to that. We had a situation in a state a couple weeks ago where, about a month ago, that claims just inappropriately denied. They were there, they were where they're supposed to be, and the payer didn't have it configured right. And a lot of people got claims denied. And one provider actually said that they weren't going to be able to make payroll if the state didn't reprocess the claims. And that's a horrible position for smaller agencies to be put in. You know, they're trying to comply, they're doing everything right, and then they, by no will of their own, now that they can't make payroll. I mean, that's something as payers we have to be very cognizant of. If we're going to implement something that impacts people's revenue, we have to make sure it's working right. So that's a challenge. And then another challenge that I see, and even I had a conversation with the state about today, is some of the vendors just can't comply with the state's EVV requirements. They could, they just don't realize that they're not. So when we have a state who's live for years and they've just not been denying claims, providers had no idea their revenue wasn't going to get impacted. And I also scream this from the roof. If you're in a state where the claims are not denying today, please do not look at your vendor's remittance information because they do not look at paid claims for errors. So I'm going to take Delaware as an example. I was on a call today and they've been very wonderful with their providers, and I gave them this feedback today as well. And one of the things that I've seen trip providers up across the country is the vendors are telling them, you're going to do great. Claims denials are coming up. I'm seeing no errors. Things are perfect. But when claims denials start, oh my God, the avalanche is here because the vendor is not, I'm going to call it parsing paid. They parse denied to pull out those errors that happened that cause the denials. So that's one of the things that I mentioned on the stakeholder call today is please don't look at your vendor's remittance devices, look at the payer. The payer is your source of truth, and that's where you're going to find out if you actually are ready for claims denials or not. So that's something that please do that. But when vendors aren't configured, like for rounding rules, that's another area where providers have a big struggle with some of these vendors is that they can't configure to the state's requirements. I'm working with a provider now who has a lot of money denied because her vendor doesn't have the rounding rules correct. So we have to go in and try to correct things so that it works right. So it's important that providers on an operational level make sure you're looking at your remittance devices to make sure that everything's matching. Log into the aggregator. I was surprised at how many providers didn't know how to get into the aggregator before claims denial in another state. It's critically important that you log in there. Make sure that your vendors are responsive. Um, I have a lot of people ask me about what vendors do I recommend, and different needs are different vendors. So I'll never just say out loud which one I want, but make sure they have support. Customer support is the number one issue when it comes to vendors. Make sure that they're responsive, they'll work tickets. With providers their vendors will get on weekly calls with them and work through issues and make sure things are corrected. So that's going to be a critical piece of your business, not just with EVV, but also with anything else the state's putting forward. And one of the things to remember is vendors are not just working in your state, they're working across multiple. So they probably have a lot of payers telling them, you need to do this by this time and be compliant by this. The sooner you find the issue, the sooner they can get it corrected and the sooner you can be compliant. So it's just really important for those who aren't getting denied for EV right now, don't ignore it because you're not getting denied. Vendors can take a long time to course correct. So it may seem simple, but it may be some heavy logic on the background they have to change. So make sure you're staying engaged and you're looking through all of your book of business and that everything is looking okay. Otherwise, you may find yourself at either the manual entry and edit compliance threshold enforcement and you're not ready, or it may be that the claims denial started and you thought you were ready and you're not. And that can close a business, to be quite honest. It can close a business and that's sad. So that's one of the big messages I put out there. Just stay engaged and make sure that your operations are running the way you need to. I know that there's a struggle with providers right now and their caregivers not clocking in and not maintaining compliance. It's really important to have policies and procedures in place so that you can do the step up to and termination. I know that there's a caregiver shortage, so that's scary to talk about termination, but it's also scary to think that the state's going to terminate you if you're not compliant. So we have to make sure our caregivers are complying now. And if they're not, replace them with someone else because all agencies are going to have to go through this, everybody. And, I know there are some agencies out there, and I've heard this, they're allowing manual entry and edit of all visits because nothing's being enforced yet. So these caregivers who are getting in trouble at agency A are running over to agency B, and it's making it hard for agency A because they're making their caregivers be compliant, and those who just don't want to deal with it are going to agency B. So I know it's tough, but it's your bottom line and your provider certification at the end of the day. So, I know the Department of Labor doesn't give us a lot of room to work with when it comes to EVV and clock in and clock out, but there are things you can do. So that's, I know I've talked a lot. I want to make sure I hit a lot of stuff because I don't have a lot of time. So do we have any questions? Do we have any comments or?
Well, Kristy, and this is where I'll jump in. We did have some questions submitted before, and I actually have one myself. So I think let's go through those. And then if that reminds you of other points in your closing, that would be excellent. You've mentioned it. Those of us who've been working in this for quite a while know EVV has been around for a long time, but the mandate came out about 10 years ago. So there's been a lot of effort and work to meet certain deadlines. With that comes provider fatigue around EVV. And I know you see it. Like they don't even want to hear the word EVV.
Yep.
With the fatigue, what should providers be focusing on right now? What's in front of them, and what do you think are the next big things that they should just be aware of?
So if it were me, one thing that keeps me focused, and I've been saying for years, that why do we get into this business in the first place? To make sure people get the care they need. And it's hard when you see all the regulations coming at you. You see the state saying you're failing here, you're failing there, providers, caregivers saying I can't do this. There's a lot coming at you every single day, and it can make you forget why you were here in the first place. So look at that success case that you have at home, or maybe someone that you were able to nurse back to health and they no longer need you anymore. Those success cases or those critical cases that you've helped them stay out of the nursing homes, that's your reason for continuing on. I mean, even sometimes I live EVV, and sometimes it's like, oh my God, we're going to talk about EVV today. Of course we are. This is what I do for a living. But it's hard when you just have so many issues and so many different things going wrong at all the same times to continue down that path. So my message is remember the reason you're here. That's what keeps you going.
That's great. And obviously it's such a hot topic that Nola wants to join. So let's go to the questions that were submitted previously. Where are you still seeing the biggest differences in EVV requirements from state to state that are creating operational challenges for providers?
I think manual entry and edits are one of the bigger headaches I see right now because some states aren't enforcing, some are over enforcing. So we have providers who have been actively trying to make sure that they're compliant with EVV, but then we have a state come in and say, well, we're going to drive 100% enforcement of manual entries and edits. So we have someone who is compliant who is no longer compliant just because of the way an aggregator calculates compliance. So that can be very disheartening for providers and very challenging. So I think that's one of the bigger things outside of claims compliance right now. Manual entry and edits are kind of the next big thing.
I would agree wholeheartedly with that. So another question that came in, what are the most common operational breakdowns you're seeing that lead to EVV noncompliance today? And I'm sure it's similar to the manual entries, but are there others on top of the manual entry process?
Absolutely. Ownership. Providers have to have someone own the EVV data. So making sure the workflows are worked, making sure the rejections are worked, making sure someone's logging in, someone's checking the claim. Somebody has to own your EVV success, just like you have someone owning your claim success or your caregiver success or your client success. Somebody has to own your EVV success because it's no longer separate from a claim. It's going to be tied to it one way or another. So it's as critically important to have ownership over your EVV success as it is any other aspect of your business.
And then what EVV data or reports are you actively reviewing today?
I just did a training lesson over this earlier. So some of the aggregators have a very good, I'm going to try to stay away from names so we don't give away vendors. But one of the bigger aggregators has a review that you can just go on and it's kind of ad hoc. You can run it by the date, you can run it by caregiver, it's basically what the Cures Act states have to certify to get increased funding from CMS. And it's one of the things that they say you have to have is search on this, search on that, search on this. So there's so many different criteria you can search on in this particular search field, and you can export it. You can put what headers you want, what columns you want in each one. I love just running that ad hoc report. But outside of that, the same vendor has an EVV compliance report in several of the states that they're operational in. And that EVV compliance report will tell you what the state is seeing as far as compliance. So that one's a really good one. Another vendor actually calls in an EVV compliance report, but they do it by caregiver, they do it by visit. They actually have a very expanded compliance reporting database so long as the state has approved it. You're not going to see the same compliance reports in each state. So what I would say is no matter what system you're in, take a look at just your visits in general to see if there are any manual entries or edits, if there's any reason codes. Reason codes are going to be your number one hit when it comes to figuring out if it's a manual entry or an edit. And if there's any claims, some of those vendors that submit the claims for you, look at their billing reports to see how that's going. So, I mean, there are reports in these aggregators that can help you determine what might be failing or what might be coming down the road.
So, and I'm going to take it just a step further. I know this is geared more toward providers, but anyone could potentially want to learn more about EVV. So, whether it's you're a provider, whether you're an EVV vendor, whether you're a state, I think best practice is transparency in the reporting. So, you're all working off the same data.
100%.
Okay.
100%. I actually, on a call I was just on earlier, someone's vendor said they were 100% compliant and the state had a different opinion. So it's very, very important that everything align. And if your vendor's not aligning, find out why and then fix it.
And it's not just the reporting the data, it's the definition of what is compliant 100%. And how that ties into the data that's being reported.
Yes.
So
yes.
Okay, just a couple more questions that were submitted. And one is, if a claim denies due to an EVV mismatch, where should providers focus first? Fixing the EVV record or correcting the billing?
So it's a little of both. Look at your remittance advice, find out what you build. So we always want to look at the payer, program, service, the member, make sure their Medicaid ID is right, make sure that the data service is right, and make sure that the amount that you're billing lines up with what's in EVV. So if it doesn't, if you're using the state's free system, go in and edit that visit so that it matches what actually happened. And here's the thing to remember, you have to bill for what actually happened. So if that claim is correct, but your visit isn't, then make sure the visit is updated. But if that visit is correct and you need to bill for less, then you need to change your claim. Once everything aligns, then you can go in and resubmit your claim.
And then the last one that was submitted previously, if your state isn't denying claims or tracking manual edits yet, what would you need to have in place operationally to be ready when they do?
Have an EVV team. It doesn't have to be a big team. It could be someone, and one of the things that I've done with a few providers is get your revenue cycle or billing team and get someone from your operations team and have them have a weekly meeting on EVV. Where are claims? How do they look? how does EVV look? Have them talk to each other because you would be surprised how many provider agencies, they're fragmented. So the billing doesn't talk to operations or vice versa. And once you come into a room for EVV failures, you're like, everybody's blaming each other. Well, no, if you fail, we all fail. I mean, this is an us ship. It's
Mhm.
not a our, So it's making sure that those people are in a room and talking. And if it has to be weekly, do it weekly. If it's biweekly, it can eventually go further out spaced. It doesn't have to be weekly for the rest of their lives. But at least in the beginning, make sure that you're compliant with your claims, make sure you're compliant with your operations, and then start looking at your manual entry and edits. Once your claims and operations are smooth, projections and exceptions are getting worked, claims are getting resubmitted, now we can look at, okay, what are the caregivers doing? And there's plenty of reports in just about every aggregator that will tell you what your caregiver is doing. So you want to look at those reports. And if they're manual entry and edits for 2 or 3 different caregivers, but the rest are doing wonderful, you know where to focus. If there's manual entry and edits for one client, and maybe it's not the caregiver, maybe it's the client, then okay, what's going on with this client? Is this someone who's not going to allow us to be compliant? How can we work with them? So it's finding out the root cause of why you may have compliance issues. And you can only do that if your billing and operations are working together and if there are escalation points for both. So that's, yeah. And don't bill off the schedule. Please don't bill off the schedule. You have to bill off your EVV visits because that's what actually happens. And I have seen that. I'm going to say this sounds really harsh. I have indicted people for billing off the schedule, and the person was in the hospital. So make sure you're billing what actually happened in the home, not what's on the schedule. That is the big thing. If I had to leave anything with providers, please don't bill off the schedule.
Well, Kristy, that was a great nugget. I am going to give you one more opportunity. If there are any other nuggets you'd like to share, this has been excellent information, but I want to give you some time for any closing or, like I said, closing nuggets that you want to impart on us.
I feel like I've thrown so many nuggets already. So I would just say it's going to be okay. That's what I tell providers. That's what I tell my clients. It's going to be okay. And I think Jennifer has a question.
Oh, Jennifer does. Thank you, Jennifer.
I do. I do. So I work on the payer side for a managed care organization specifically. And I'm curious to understand if states, a lot of the times that relationship between the state and the payer can be a little bit adversarial.
Yeah.
And, there is definitely a cost savings when we look at what EVV brings to a state. Are there any states that you've run into that do share that information, maybe give incentives to a managed care organization if they're managing it on behalf of providers? Do you see any synergies anywhere there?
The only I don't want to call states out or the way they've done it, but the states that I find that has the most synergy with their managed care plans are those that actually share aggregators with them.
Okay.
It's because now the managed care plan has access to everything the state would have access to related to their members and providers. And I think that brings a level of transparency that some other states may not have. And it also provides a transparency for the state because now the state can see what's happening on the MCO side versus when we have the MCO option states, the MCOs may have their own aggregators. And now
Sure.
they're waiting on the MCO to send the data to the state because now the state is responsible for reporting that to the federal government. So it's making sure that there's accuracy in data that makes it difficult. So I think there's a lot more synergy around states who share the data back and forth, whether it be having the same aggregator or having,
Right.
like you said, that transparency. I think there's a lot more there. I can tell you one of the states that has recently gone through with claims denials has been very engaged with their managed care plans, and that if the MCOs are having issues, that there's an open communication between the state and MCO. It's not a, well, send this generalized box and we'll see if we can get to it. It's they're working together as partners to make sure that providers are being successful. And they're saying you must train this, you must train that. I've not seen incentives per se on if your providers are more successful that might be behind the curtains. I know that in one of the contracts I read in one of the states, there were some incentives for successful claims implementation, which could be taken bad or good.
Okay.
But yeah, so I haven't seen on the front the incentives piece of it.
Okay. Thank you.
Welcome.
Jennifer,
Thanks
I'm
for
going to
asking the
tag on
question.
to your question real quick about the incentives and Kristy, just from your perspective of what you've seen in the industry and what's coming forward, we know value-based care is important. Interoperability is a big policy requirement right now. Do you potentially see incentives in the future where EVV is linked to value-based care in any form or fashion.
Now, when we talk about incentives for providers, there are a couple states that offer incentives for providers who get their visits in incorrectly. And I think it's going back to that value-based care, making sure that the care is being delivered and is being done well and compliant. So there are at least 2 or 3 states that offer incentives based on a rolling date. So it may be from, September to July the next year, or it could just be by quarter. So I think states offering providers incentives is a really good idea because that helps them with the administrative burden of trying to get EVV rolled out well. And one of the things that I heard over and over and over when I was at the state is that the administrative piece of EVV is covered in the administrative reimbursement that's already as part of the claim. And having worked now on the provider and vendor side, I would like to say, no, ma'am, it is not. I mean, EVV is a full-time job, and that small bit of administrative reimbursement that's part of the claim does not cover what providers have to do with EVV. So I think giving an EVV incentive will help providers get the people they need to be in a better place with EVV.
I'm going to see if there are any more questions. All right, looking at see if there are any direct messages as well. Again, Kristy, thank you so much for your time. This has been very enlightening. This will be available on HHS Connect's YouTube channel. Any last parting thoughts?
Nope. All I'd say is it takes a village to raise an EVV. So let's all just partner together and get through it. And we'll be looking back at this, laughing together in a few years.
Wonderful. Well, thank you all for participating. And thank you to anyone who does watch us online. Please reach out if you have any questions or want additional information.
Thank you.
Thank you, everyone. Thank you, Kristy. All right, take care.